Hello, everybody. I'm back, Dr. KK Agarwal, Heart Care Foundation of India, and you are watching Med Talks with Dr. KK Agarwal. Now, let's have the topic of the day. With the advent of home care, more and more patients not visiting the hospital, staying at home, preferring a home care, they are being denied of a good bed sore care. They are developing bed sores. So therefore, the talk today is prevention and management of bed sores. Before I introduce you to the speaker, let's have our ritual of Atithi Devo Bhava, and that's we wash our hand called Suman Ke, S for Sida, U for Ulta, M for Mutti, A for Angutha, N for Nakhun, and K for Kalai. Once we have done that, let me introduce my Atithi, my special guest, Dr. Jayakar Thomas, Emeritus Professor, the Tamil Nadu Dr. MGR Medical University, Chennai, IMA Professor of Dermatology, former National President of Indian Association of Dermatologists, venereologist and leprologist. He has around 40 years of experience, recipient of numerous awards, including Lifetime Achievement Awards for teaching, Mother Teresa International Award, and IMA Best Doctor Award. Published over 250 original articles in the various fields of dermatology. Now, he is going to speak, and after that, we will interact. The subject is very clear, and that is and prevent bed sores. I know that when I was in the council, a large number of cases used to come for medical negligence that my patient was bed sore was not taken care of. In a council, how do we evaluate whether this is a bed sore because it had to happen, or it was a bed sore because of a medical negligence? The answer was very clear: whether due precautions were taken or not, whether due care was given or not. If due care is given and still if you develop a bed sore, that is a because of the underlying malnutrition or immunological problems or infection, and that due care basically involves is understanding the concept of avoiding pressure, avoiding friction, avoiding the shearing forces, and avoiding any type of a moisture, specifically the urine and stool. And with this, I invite Professor Jayakar Thomas to give his presentation, and then we will have a discussion on that. He will also be focusing on silicone gel as a method of prevention of bed sore, taking care of the friction and taking care of being a water repellent, taking care of the moisture also. Dr. Thomas.
Good evening, everybody. Thank you very much, Dr. KK Agarwal, a very popular man for disseminating medical knowledge to the medical fraternity as well as to the general public. I have just a very short presentation in which I shall highlight a few points on pressure ulcers or pressure sores, whichever you may call it. As you can see here, multiple terms are given: decubitus ulcer, pressure sore, pressure ulcer. They're all used interchangeably. But then came the National Pressure Injury Advisory Panel, which currently considers pressure injury to be the best term to be used, given that open ulceration does not always occur. So skin can still remain intact in a pressure injury. Accordingly, a pressure injury is localized damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical or other device. It can present as an intact skin or an open ulcer and may or may not be painful. It occurs as a result of intense or prolonged pressure or pressure in combination with shear, which obviously means that we should keep our eyes and ears open to really be able to diagnose this. Now, if you were to look at the etiology of pressure ulcers, impaired mobility is the most common reason. And that is the reason for patients to get exposed to prolonged uninterrupted pressure that causes pressure injuries. Now, this situation may be present in patients who are neurologically impaired, maybe those who are having a paralysis, heavily sedated or anesthetized patients, restrained, demented, or recovering from a traumatic injury. Supposing there's a fracture at the hip bone level, such type of people are likely to develop this continuous impaired mobility. They cannot alter the position, they cannot move around, they cannot shift, and therefore there's bound to be, because of the prolonged immunity, muscle and soft tissue atrophy, decreasing the bulk over which bony prominences are supported. Now, in addition to these, which I have already said, trauma that causes de-epithelialization or skin tears removes the barrier to bacterial contamination and leads to transdermal water loss or transepidermal water loss, creating maceration and causing the skin to adhere to clothing and bedding. In other words, it can become an entry to microbial infection. For the purpose of a workup, it is helpful to stage the pressure injury as follows. Stage 1, non-blanchable erythema of intact skin. So that's the time when we should be able to catch these patients. That's why I said keep eyes and ears wide open, because when the skin is still intact, if we catch them, that's the time when you could treat them easily just with medical treatment alone. Stage 3, partial thickness skin loss with exposed dermis. That is, only the epidermis is lost. Stage 3, full thickness skin loss, epidermis, dermis, and part of the subcutis. And stage 4, where skin and the underlying tissue, fascia, maybe it might go up to the muscle also. And there could be unstageable pressure injury, obscured full thickness skin and tissue loss, persistent, non-blanchable, deep red, maroon, or purplish discoloration means a deep pressure injury. It may the skin could still be intact, but when you get a non-blanchable redness, that's somewhat like a purpuric response, then we have to think of a deep pressure injury. Why are we talking so much? Because the complications of these pressure ulcers include a varied, I've just given a very modest list here. They can get transformed to some form of malignancy, mostly a squamous cell carcinoma. Then what we call as autonomic dysreflexia, osteomyelitis goes down to the bone and to the joint, pyoarthrosis, sepsis, generalized sepsis, urethral fistula, long-standing amyloidosis, which can move on to the kidneys also, and commonly anemia due to continuous loss of blood. Now, how are we going to really assess and start treating them? As I told you, the best is to catch them early in stage 1 or stage 2, when only medical treatment and non-operative procedures are enough. Whereas for stage 3 and stage 4, we might have to give surgical intervention. The minimum would be a flap reconstruction. Now, all these are not going to be easy in a home setting. We are talking about a home setting with our hands being handcuffed because of the current pandemic. Now it becomes really difficult, really difficult to manage these very ill patients and bedridden patients. And it has been estimated that over 70–90% of pressure injuries are superficial and heal by second infection. That is God-given gift to human physiology. Now, medical management, that is stage 1 and stage 2, will include reduction of pressure. Now, how do we do that? There are varied methods. We know that time-old water beds that are being used, you can use something like your rotatable pillow and make sure that the patient keeps moving, and good nursing care, debridement of the necrotic and devitalized tissue, control of infection, which becomes very important. But then in a bedridden, particularly senior citizen, it becomes difficult to keep on giving antibiotics. And wound care becomes important. Apart from the debridement, maybe an application of an antimicrobial ointment or cream would be helpful. I would certainly recommend an ointment because it will not stick. A cream is likely to dry up fast and stick. When it comes to surgical intervention, when we have to use a replaceable flap, then there are lots of things that we have to look into. One has to control the spasticity in the patient, enough nutritional support. Dr. KK already told us about this nutritional support, cessation of use of tobacco as well as alcohol, and adequate pain control. Now, quite a few of them may be painless. That's why they are not detectable early. But when there is pain, it can be tremendous pain, particularly when it can affect somewhere near the spinal cord. Now, there are barrier creams. Now, these barrier creams are just like sandwich fillers. If you look, there is a skin surface, and look down, there's something which is causing pressure or shear. Now, we want to fill up that gap so that there is no direct contact of the intact skin with the lower lying, whether it's the surface of a cot or whether it's the surface of a bed or any other medical device. So an evaluation of barrier films and creams indicates the importance of barrier protection as an essential component of pressure ulcer prevention. I've given the relevant reference there. And one should accept the fact that prevention and management of pressure ulcers or pressure injury, as what they are called now, 90% of the credit will go to the nurse that is being employed to take care of that particular individual. So good nursing care. Now, Dr. KK also told us about the silicone-based barrier products. I'll just dilate a little bit on it. They have been shown to be effective in protection and management of peri-wound skin. That is important. Not only the wound alone, but the skin around the wound, because these formulations of silicone may include micronutrients and antioxidants. Now, antioxidants become very important because in these long-lying patients, there is always a breakdown in the antioxidative stress. So we should be able to, the defense mechanism is broken. The antioxidant defense mechanism is broken, or is the stress brings it down, and therefore enough antioxidants should be replaced, and silicone is known to do it. Now, what are the other properties of silicone barrier gel? An anti-friction gel, a silicone elastomer preparation, which forms a uniform friction. As I told you, it's a filler of a sandwich. Friction lowering, flexible, water repellent barrier film when applied to unbroken skin. So it should be given in stage 1 itself or even pre-stage 1. Barrier film formed by the gel inhibits direct contact between the skin and clothing or bedding, thereby helping to relieve discomfort due to skin irritation on pressure-prone areas and prevents it from developing into a bed sore and helps preventing bed sores. And also, as again, Dr. KK had pointed this out, incontinence of urine and feces, which always or frequently associated with these elderly patients who are bedridden for a long time. The reason why we are talking so much is with this pandemic control, they are not admitted to hospitals. So again, we are handcuffed to keep them only at home. And the best thing would be preventive skincare, where we talk about several aspects. Now, the causes are multiple there. So we should be able to prevent the pressure ulcers in bedridden or in patients who are been on the wheelchair for a long time, patients with stroke and paralysis, patients on oxygen ventilators, post-surgical cases, as I told you, particularly fractures in the lower limb, patients with neurosurgical intervention, orthopedic patients, and terminally ill patients who are in a comatose situation. Thereby, we prevent prevention of moisture-associated skin damage. And these are the patients who have incontinence of urine and feces, and a lot of moisture is there. So not only on the skin, not only on the stomal tissue, but peristomal MAST, that is moisture associated skin damage. That's for it from now. For the time being from now, I have the pleasure of interacting with Dr. KK so that we can talk some more on it.
Thank you for a wonderful presentation. Now, this silicon now is available in the country, both in the form of sheets, layers, and other things. Now, we normally need to give it as early as possible. So do you think this is cost effective? Because people are asking this question of cost effectiveness of silicone gel.
Yeah. Now, whenever we look at the expense point of it, there's also always a point, a phenomenon that we call as pharmacoeconomics. Now, considering the cost of treating these patients post-pressure injury, definitely it is cost effective to make use of these silicone gels. That would be my very humble opinion on this particular question of yours.
That's what I also wanted to say was because a bad bed sore leads to very high mortality, a long care. Often you end up in a hospital for a longer period of time. A complicated bed sore dressing itself will be costlier than the cost of
Certainly.
So therefore, and the antibiotics, once you get an infection, antibiotics itself may cost 10,000 rupees a day. That's how the bed sore prevention is very, 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 very important. That's one. Number two is once I put a silicone gel, how long, after how much time I need to change it?
That will definitely again vary from one individual to the other, depending on the size of the ulcer, the depth of the ulcer, as well as the convenience of the patient as well as the caregiver. I would say somewhere from 4 days onwards, you can keep it and change it every fourth day. That should be good enough.
Okay, so every twice in a week, you may need to change it.
Exactly, twice a week. That's a reasonable period.
Yes. All of us have remembered the word because all of us have known there is something called as a facial mask, and we say that the inner layer is water absorbent and the outer layer is water repellent. So all of us have understood, all of us have been talking about the word water repellent. How important is the water repellent quality of a silicone gel?
Yes, now when we come to the physiology of the skin, the dermis is so full of water, and when it is not covered by the epidermis sufficiently, it's bound to cause more of pressure around the blood vessels, and necrotic tissue is bound to occur more and more. Therefore, it can be summarized that the water repellent capacity or the property of these silicone gels play an important role in continuous management of pressure injury.
So when I place a silicone gel, my duty doesn't get over of not shifting the patient frequently, not giving them adequate nutrition, not taking care of other things. How important are parallel management along with the silicone gel?
Very important. Very important, Dr. KK, I must tell you, because as you rightly pointed out, KK doesn't stop with this application of silicone and being complacent with the patient. Complacency is one thing that is going to worsen a pressure injury. So we have to continue about trying to keep the patient moving from side to side, must continue to give the antibiotics whenever indicated, and very, very important is the nutrition that is given to these patients. And it's very difficult. It's very easy for me as well as for you to keep talking that nutrition is very difficult to make feed a patient who is in the bed continuously 20 hours a day. Maybe 4 hours he or she is propped up by the nurse who is by his or her side.
So what about when we come back to the nutrition? When we talk about the nutrition, what do you want to cover? The calories or the protein or the both?
Proteins. Calories can be also taken into consideration, but that can be kept low, doesn't matter. So low glycemic, high protein.
So high protein can be even whey protein, you can use it.
Now there is a question, easy, whey protein.
Sugit Tandon is asking a question. Pressure ulcer due to prolonged sitting in elderly female who is not bedridden. Solitary ulcer near ischial tuberosity. How to manage?
The answer lies in the question, prolonged sitting. So we must try to avoid, and then give a type of a cushion that is circular with, it's a ring shaped, in short, a ring shaped cushion that could be given for these elderly females or males who are sitting for long hours. And again, trying to move the individual as frequently as possible. And ischial tuberosity is one thing, can cause a lot of pressure. People who give long lectures say, I don't want to keep the lecture long because that's going to end up with ischemia of the ischial tuberosity. Jocularly, that's said that way, you know. So ischemia of the ischial tuberosity is not at all rare, not at all rare, and one has to be aware. And it's really a good question from Dr. Tandon.
Another question which has come is, they want to know about the airbeds. How do we use them? What is the importance?
About the air bed.
Yes, the bed with the what we call them as
waterbed.
Waterbed. Yes, there are also air beds where instead of water they pushed in the air.
Yes, yes. The idea of a waterbed or an airbed is to sort of distribute the body weight equally. That's the idea of giving it, trying to make the weight get redistributed in a way so that it doesn't cause pressure in one localized area. That is the idea of it, and therefore it does play a role.
The next thing, another question which is asked is a very simple question, and they want to know that if there is an infection, which are the common organism and which antibiotics to work?
Actually, it appears to be common, but it's an important thing. One has to realize that it's not the usual common garden bacteria that get involved. We must keep in mind when the skin is being closed and not exposed to atmospheric oxygen, anaerobes are bound to grow. And keeping anaerobes in mind, I would certainly love to add metronidazole along with any other antibiotic that is being given. An antimicrobial as well as metronidazole will help, and that will take away the anaerobes, take away the foul smell that is likely to come.
So those who are watching on the social media, Dr. Thomas has clearly said there are two types of organisms, aerobic and anaerobic. When it comes to anaerobic, the drug of choice is the same medicine which we give it for diarrhea, that is a colonic or a large intestinal diarrhea called amoebiasis and giardiasis, and that is metronidazole. That's what he meant, that also takes care of the anaerobes in a infection with that. The next thing they're talking about is, they're linking it to COVID-19 and they're saying patients with bed sores, should they be given COVID-19 vaccine?
They can be given. Why not? I would like your opinion, Dr. KK, on that.
They should be given early because these are the people, all immunocompromised people should be given early and as much as possible because you need to take care of them over a period of time. That's what it is. Another thing, let me ask, is there, most of the questions are not related to the subject, so I'm not taking it up. There is a person from the patient point of view, one in asking, what do you mean by the word shearing versus friction versus pressure? What is the difference between pressure, shearing, and friction?
Yeah. Now, pressure is something which is there continuously. I'll show it. When there is continuously, there's pressure. Now, friction, intermittent, comes on, goes away, comes on, goes away. A common example of that is what you get as a callus formation over the soles or over the sides of the feet, or the malleoli, particularly the lateral malleoli, which you can get callosities or corns. That is due to regular friction. And the third terminology, which you call a shear stress, is a movement stress, or mobile. I would certainly give a good example of that to be, supposing a person, for us to imagine easily, is having what is known as a high stepping gait. Now, when the step is high, is likely to be having an excess shearing force. So it may not be, if for example there's a foot drop, it may not be the sole that gets affected, but the surface that comes. That is the shearing stress. So these will be trying to make it as simple as possible, pressure, intermittent, as well as a shearing.
The last question is related to the pressure injury. And the last question is, they want quickly to summarize the skin dermatological manifestations in COVID.
Yeah. I will tell you very quickly and very briefly. Number one, I'm not telling it in order of priority. I'm telling it from above downward. Number one, they have noticed one thing which is known as a Gabry sign, where most men are bald who develop this. That's only a coincidence, I personally would feel. But however, this Gabry sign has been documented. The next thing is a generalized rash, which looks very much like a measly rash, or maybe even like a chicken pox, like varicella. The third possible thing is reticulate pigmentation or net-like pigmentation, which we call as divilloreticularis. The next thing which is known is the necrosis of bluish discoloration of the toes, classically described as COVID toes. So that is another manifestation. Now, other manifestations seem to be very non-specific, and they really don't fit in. They can get, they're all immunocompromised, they can get fungal infections, bacterial infections. But these are some of the things that are being put down to be clearly associated with COVID-19, Dr. KK.
The last question is post-COVID hair loss after 1 month. Post-COVID hair loss after 1 month. How to manage?
That is what we tend to call as telogen effluvium after any prolonged illness. It might be typhoid fever, enteric fever, there's bound to be hair loss. Now, that is generally reversible, if it does not reverse, then probably you might have to consult a dermatologist. And what can be given is maybe 2 to 5% minoxidil externally for a brief period, not for too long a period, for a brief period. When I say brief, 4 to 6 months, and stop.
So that's all what we have talked about it. So let me summarize. You need to understand whenever there is a bed sore, anticipate. So anticipate that this patient is likely to get a bed sore and start acting at that particular moment. Before it develops stage 1 or during stage 1, now you anticipate that it is now going to end up into stage 2, and that's the time to intervene. And one of the things which we have talked about today is a barrier that is a silicone gel, which takes care of the pressure, friction, shearing force, and which is water repellent, so that even if you pass urine and stool, it doesn't affect. It can be used twice in a week, and you may be able to prevent a bed sore from developing from stage 1 to stage 2. Once it develops stage 3, 4, and others, you know that surgical debridement is needed and other treatments are needed. So let me thank Professor Jayakar Thomas to be here. And all of you, if you have any other question, you can still post your questions. They will come back to us. We will keep answering your questions. So let me thank Professor Jayakar Thomas to be here. And that's all for today. We will be back tomorrow again for another show. Keep watching Med Talks with Dr. KK. Namaskar and thank you.
Thank you very much.